Now we go to our fifth session, and I do like to invite our eminent chairpersons, Dr. Anita Chakraborty, Dr. Saurabh Pal, and our secretary, Dr. S.P. Roy. Our first topic has been sponsored by Bayer Zydus Pharma, and the topic is role of Willis gut in worsening heart failure, Victoria trial. And we are very much honored and happy to get Dr. Abhijit Bhattacharyya. He doesn't require any introduction whatsoever. He is the most eminent physician in southern part of Calcutta and all around Calcutta also. So, sir will take up this topic. Please do come up, sir. Dr. Abhijit Bhattacharyya, please.
So, good afternoon. Let me first thank South Kolkata Doctors Association for giving me this opportunity to share some thoughts about heart failure and heart failure treatment, so-called fifth pillar of heart failure treatment in the form of this new drug, Vericiguat, which we are increasingly using. We all know about the four pillars, so let's see what the fifth pillar is about. So this is my basic outline. So why you should use Vericiguat, how important is worsening heart failure, this important landmark trial of Vericiguat, which is Victoria trial, we'll discuss about that, and how, when, and in whom to use Vericiguat in heart failure. So let us start with some basic definitions of heart failure. Symptoms or signs of heart failure can be caused by structural as well as functional. You have in heart failure with preserved ejection fraction, you don't have any structural problem, but you have a functional problem, and should be corroborated by at least one of the following: elevated natriuretic peptides in the form of either proBNP or N-terminal proBNP, and you should have some objective evidence of either cardiogenic pulmonary or systemic congestion. Now, one caveat about this N-terminal proBNP. So, in certain situations, it can be false normal and it can be falsely low as well. So, if it is age related, if your age goes up, the normal cutoff for N-terminal proBNP also goes up. So, if you have someone which is 75-year-old, the normal cutoff is 1,800, as high as that picogram per ml. So, please be, while considering the value of N-terminal proBNP, please consider the patient's age. The second important thing is obesity. In obesity, you can have a falsely normal N-terminal proBNP. So, if you have documentary evidence of other heart failure, so just don't be taken away by the low or normal N-terminal proBNP. And of course, the most important is renal impairment. If someone has CKD, it is most important to rule out heart failure by having a normal proBNP, because in most situations, you'll have a high proBNP if you have a renal impairment. So these are some caveat about interpretation of N-terminal proBNP. So worsening heart failure, why should we care? You can see this cartoon of JAMA, and you see as the patients are getting admitted, they're going out and again getting readmitted. So this is the problem with worsening heart failure. If you have a worse heart failure, your readmission rate, your rehospitalization rate goes up tremendously. How often? Chronic worsening heart failure accounts for 80% of heart failure hospitalization patients. So one episode of heart failure begets another heart failure hospitalization. 1 in 2 patients will be hospitalized again within 30 days of their worsening heart failure. So goes home, again comes back within a month. And 1 in 5 patients will die within 2 years of their worsening heart failure. So worsening of heart failure is very important to prevent rehospitalization and to prevent mortality. And heart failure is a sort of continuous process. It's a progressive condition. It's like almost like malignancy. Unless you have treat adequately with evidence-based medicine, it goes on, it progresses, it worsens. So if you look at this x-axis of time and clinical risk, so initially there is no heart failure and heart failure risk is not at that high. If you have some baseline heart failure and you treat with proper medicine in the outpatient or hospital, maybe a window period of 3 to 6 months, but still, even after initiation of GDMT, there remains some residual heart failure risk, even after putting an ICD or CRT, if there is indication, which can vary between months and years. And if you have a worsening heart failure risk, see how it climbs up. So worsening heart failure, despite optimal medical and device therapy, is a real condition. And if you have an advanced heart failure, which is refractory and patients cannot tolerate GDMT, you have to have no other recourse but to consider heart transplantation or mechanical device, and which is basically kind of palliative therapy. So if you want to define what is worsening heart failure, this is obviously characterized by progressive signs and symptoms of heart failure, despite the use of guideline-directed medical therapy. And of course, after up to a few years back, the 4 pillars of HFrEF, particularly heart failure disease ejection fraction, beta blocker, MRA, and SGLT2 inhibitor, and ARNI. These are the 4 pillars. So if there is no contraindication and if patients tolerate, patients should be offered these 4 drugs, which are the 4 pillars. And now we'll discuss today what is the 5th pillar. And patients with worsening heart failure must have a proper prior diagnosis of heart failure, and they should need intravenous diuretic for the decongestion, regardless of whether they are hospitalized or regardless whether they are as an urgent heart failure hospitalization visit. So where does vericiguat fit in? So the Victoria trial population was here. It was here where the heart failure was progressively declining because of despite treatment. And as we have already discussed, that worsening heart failure is associated with a poor prognosis. And if you look at this study, which was published a couple of years back in JACC, and which is called Pinnacle Registry, it was found that 1 in 5 patients died within 2 years of their first worsening of heart failure event. So this is a very, very serious condition. And each worsening is associated with a recurrent hospitalization. Each visit begets more visits. And again, from this Pinnacle Registry, if you see, from the first 30 days, where it is maximum, and then progressively goes up. So 56% of patients are hospitalized within 30 days of a worsening heart failure event, and on an average, patients are hospitalized twice in the 2 years following a worsening heart failure event. And risk of CV death or heart failure hospitalization is highest in the early phase, as I told. So if you look at paradigm trial, which in fact brought in a paradigm shift in our treatment of heart failure. McMurray and his group published in NEJM in 2014, and after that ARNI has been established as one of the 4 pillars of heart failure treatment. If you look at that study, so initial 3 to 6 months or around about 3 months, which is the most vulnerable period. So patients are supposed to get readmitted in this initial period. And risk of heart failure death and CV death was 46% higher in patients who have been hospitalized recently, vis-a-vis patients with no history of hospitalization. So the initial period is very important. Now, even after offering them with GDMT or so-called 4 pillars, does the risk go away altogether, or is there any residual risk? So the residual risk is there, of course, and that is why the question of now prescribing vericiguat comes. So if you look at all these landmark studies, paradigm HF, which I've described just, where the